Hi everyone, welcome to ResearchMD.com. My name is Pramil Cheriyath. I work as a physician. I'm a program director in internal medicine residency, transitional residency, and a director of research, and I hold 2 assistant professorships from major universities. So today our topic is upper gastrointestinal bleeding or upper GI bleeding. So we're going to teach you all about upper GI bleeding, the causes, how do you manage, and all about upper GI bleeding we're going to teach, okay? So definition, what is upper GI bleeding? The upper GI bleeding is the GI bleeding which originates from esophagus to ligament of Treves, okay? We got this nice picture drew for you. We got this duodenum, the stomach and the duodenum, then you got the third part of duodenum, and then you have the ligament of Treves. That's where the buck stops. After that, it becomes lower GI bleeding. Anything below that is upper GI bleeding. Remember that. Ligament of Treves is very important. Just few facts about upper GI bleeding. It's more common in men and increases with age. Like everything else, upper GI bleeding also increases with age. In-hospital mortality remains high, almost 13%. Re-bleeding is common. That's what we need to worry about. They come to the hospital, they fix everything, and you go home. You're going to come back again. So we have to be very careful about that. Okay? Now, just look at the causes, the main causes. You got the peptic ulcer bleeding. It could be like a gastric ulcer. It could be duodenal ulcer. Esophageal virus is a huge topic. People with alcoholic liver disease and AV malformation. There's Mallory Weiss tear, gastritis, duodenitis, and malignancy. You have iodoenteric fistula. If you have an aortic aneurysm, that could happen in aortic stenosis. There's angiodysplasia causing it. So several of things, but be careful about all these causes. Past medical history, always when you ask a patient, come in, ask about liver disease because that can make them bleed. Atrial fibrillation, what happened? They always on anticoagulation, right? And then PE and DVT, pulmonary embolism and DVT, what do they get? They get anticoagulation, blood thinner, so that can make them bleed. Embolic stroke, how do you treat it? You put them on blood thinner. So all of these people, when you know the diagnosis, they know in your heart they are they're on blood thinner. That's the main purpose. Of course, peptic ulcer disease, we need to know. Gastritis, H. pylori infection is another cause of bleeding. So we have to worry about gastrointestinal angiodysplasia. We already talked about the relationship with aortic stenosis and can cause GI bleeding. Iron deficiency anemia. Previous abdominal operations also very, very important to know. Medication. Always ask about the patient's the use of NSAID like ibuprofen. How do you ask a patient when are they on ibuprofen, or don't ask them are you taking ibuprofen or are you on NSAID? The best way to ask them is always hey, do you get any headache and what do you take for that, okay? Or you ask the patient, hey, do you get joint pain? What do you usually take? And then they will tell you, I've been taking 6 ibuprofen daily. I was taking naproxen daily, okay? So we have to frame the question to get, because NSAID use is one of the most common thing, could cause upper GI bleeding, and we have to be very, very careful about it, right? If there is no point in you fixing everything, sending back the patient home, and then patient continues to take NSAID. Anticoagulation, unfortunately, some situation you don't have any other choice. If they have atrial fibrillation, if they have pulmonary embolism, you have to anticoagulate, correct? Antiplatelet agents, the same thing, and studies have also shown psychiatric like serotonin inhibitors like SSRI can also cause GI bleeding. And oral steroid is also, if you are long-term steroid use, that can cause GI bleeding. Okay, family history of malignancy, any upper GI malignancy you have to be careful about. Social history, anytime people drink alcohol, that can cause gastritis, all the gastric damage, that can cause bleeding. Smoking also contributed to GI bleeding. Drug use, cocaine, can cause vasospasm. Sexual history, why is it important? You need to know about HIV. HIV, the one question people can come is what is the most common cause of GI bleeding in the United States? You can always say peptic ulcer disease, right? What is the most common cause of upper GI bleeding in an HIV patient? What is the answer? Anybody know? It's Kaposi sarcoma in the GI tract. Okay, always remember that. So psychiatric history, we talk about the medication like SSRI. So you have all the history taken. The next step is you look at the vital signs. You see tachycardia, patient may be hypotensive. Let's say you looked at the vital signs, everything seems to normal, but don't stop there. The next step is always check for orthostatic hypotension, right? You make the patient sit up, you make the patient stand, and you measure the blood pressure in between. If the systolic blood pressure drop is, drop less than 20, diastolic drop less than 10, and the heart rate goes up more than 20, the patient had what? Orthostatic hypotension. What does that tell you? The patient is orthostatic. That's telling you you lost almost like 20% of your volume. You don't need to know anything else. You can know how sick the patient is right there by checking orthostatic. So don't forget to check orthostatic. Physical examination, next you come to the physical examination. You do a general examination on the patient, like, mainly you just kind of looking, are they volume depleted, any of the signs and all of that. And you look at the sign, sign of all the skin. The main thing you have to roll out the signs of liver damage, right? You got like the palmar erythema, you got spider angioma, gynecomastia, scleral icterus, and all of these things you need to look for. And then you come to when you come to the HEND, you can look in open the mouth and see, like, sometimes maybe a GI bleeding. You think it's a GI bleeding, but it's the bleeding actually happening in the mouth, and blood is dripping down to the GI tract, right? And then you can also looking at the pigmentation and see the patient have any Pierce-Jagger syndrome. And also when you look into the neck, what are we looking for in the lymph node? The left-sided lymph node is the one important, okay? When you have this called a virtuous lymph node, that kind of tell us if the patient have malignancy or not. So it's always important to check for the node in the left supraclavicular area. On the right is pretty much the lung drains into it, so always look for the left supraclavicular lymph node, virtuous lymph node, and see if it is positive. Then you have to think about a gastric malignancy. And then you come to the cardiac. Why is it important? Look for a murmur, aortic stenosis murmur, it's a systolic murmur, radiating in the carotid, and the patient is having GI bleeding. Then you have to think, there's a connection between aortic stenosis and GI bleeding, right? And then abdomen, always look for, the first thing is look for signs of perforation. You're going to have a patient have guarding, rebound tenderness, so like bad signs. You have to think, hey, there is a peptic ulcer disease, maybe a perforation kind of going on, right? And then also then you have to check about the, this palpable masses, kind of malignancy. Sometimes you'll find that. Rectal examination, always make sure they do a rectal examination, and don't just kind of do a rectal examination and then say like, oh, is hemoccult positive, right? You don't want to do that. First, always look at the around the anal area. Is there any external hemorrhoids? Is there like any anal fissure? And then you look at the sphincter tone. Is there relaxed, or is there any other problem? Then you examine the wall to look for any kind of masses, right? And you describe the smell of the stool, the color of the stool. That's the proper way somebody should be doing a rectal examination. Now come to, you are going to order the labs, right? We're going to look at the CBC. We need to know hemoglobin is dropping. It's always a good idea to find out what's the baseline hemoglobin is. We need to know leukocytosis, maybe a colitis kind of going on, or esophagitis, or any other infection would be. And then, of course, we need to know the platelet. Then based on metabolic panel, you could see like, hyponatremia because of the volume depletion. You could see the main thing you have to look for in the BMP is the serum BUN creatinine ratio, okay? If the BUN creatinine ratio is greater than 30:1, most likely the likelihood ratio goes really high to have an upper GI bleeding. So what happened? Why do we have increased BUN in upper GI bleeding? If you look at it, there's this blood clot. You have a nice picture on the right side. You have this liver, the blood clots in the stomach. It breaks down to protein, and then you go into the urea cycle, and then all this kind of usually, and then you come to the kidney. So systemic circulation, the urea level kind of goes up, okay? Remember that. Of course, you have to check the liver function test. You check the PT and INR to kind of tell us like, synthetic function of the liver. Also albumin, check it to make sure like your liver is functioning is okay. So PT, INR, albumin kind of tell you about how strong your liver is. Now, management, always the first thing to make sure like the patient is stable. We check in the vital signs and IV fluids, make sure 2 large bore IV lines patient has, and always, I don't care, whatever the hemoglobin, I always write an order for type and cross. You never know what's going to happen. Most of the time, the hemoglobin values initially come in, they're wrong anyway, and then 4-6 hours later, a patient have a massive bleeding, and then you kind of scratching your head and say like, hey, why didn't I order the blood? Everybody was looking for blood, and you did not order the blood, so be careful about that. Okay. Now, risk stratification. Anything come in before you start treating the patient, we need to know risk stratification. You have to know what kind of models, like there's 2 types of scoring you can use. One is Rockall score, and the other one is Glasgow-Blatchford score. So this will tell you, do you need to urgently call an endoscopy, call GI, or can we discharge the patient? All of this information, risk stratification is like very, very important, okay? So in the Rockall score, you can do one before the endoscopy, and then you can do one after the endoscopy. So you look at anybody coming to the GI bleeding, if the Rockall score is like 0, then if it is like 0, then you don't need an endoscopy. You can follow them as an outpatient basis, okay? And then if the Rockall score greater than 0, then definitely you need an endoscopy in the hospital. So, the thing they use is like 60, the age, hypotension, tachycardia, other comorbidities, and then you calculate the score. And then after the endoscopy also, you can do a Rockall score. If it is less than 3, you can early discharge the patient from the hospital. After the endoscopy, you can say like, hey, I calculated the Rockall score. It's less than 3, we can discharge from the hospital. Now, the other score we can also use is Glasgow-Blatchford score for GI bleeding. We have all these parameters, kind of plug it in. There's some formula you can just kind of, online, you can plug it in and you get a score. Okay, so that will also kind of risk stratify. If there is really low, then you don't need to kind of active intervention, doesn't need to be done right away. Both of them is like very good in assessing the risk stratification. And then you have to do like call GI and do an EGD, right? Within 24 hours is the current recommendation. Now, EGD, when you look at it, couple of things. If you see an ulcer and there's a clean base, the risk of re-bleeding is very, very low. That's a good sign, okay? But if you see an ulcer and there is a visible vessel next to it, or you see a blood clot, be worried, because these people can re-bleed. That's not a good sign. And then active bleeding from the ulcer is also a bad sign. These are the not very good signs, okay? And there's also dilophoisolation. Sometimes examination they will ask, is this posterior, submucosal, tiny arteries kind of slowly bleed? You do an EGD, most of the time people kind of miss because you don't know. And then slowly you see your hemoglobin kind of dropping down. Then you always have to think about dilophoisolation. Now, how do you treat it? Always the big part is the proton pump inhibitor, right? It kind of, you give PPI, it goes on the parietal cell and usually produce the acid. You're trying to block the acid secretion, so less damage. Okay, so you can before endoscopy, the kind of recommendation is give IV continuous IV drip of proton pump inhibitor. Now, role of erythromycin, just before the endoscopy, it's a good idea to give erythromycin because you can visualize the GI tract, which is much better. You can cause also QT prolongation, just be careful. Tranexamic acid, does it have a role in GI bleeding? No role, so don't pick that as an answer or even a treatment, okay? So when should we transfuse? That's the question. The patient come in. If there is a low risk patient, doesn't have many comorbidities, especially cardiac disease, if the hemoglobin is like 7.1, don't transfuse. If it is less than 7, transfuse. But if they are hemodynamically unstable, it's better to transfuse, okay? Let's say if you have a patient hemodynamically stable, but you have very old, and you got coronary artery disease, be careful. Then you keep the hemoglobin up to 8, okay? Now, when to restart, you did the endoscopy, when can you start the diet? The patient is asking, you want to go eat, right? If they're very stable, you can start the diet right away. But if there is stigma of bleeding or active bleeding, then at least you initially start with the clear liquid diet and then advance the diet slowly. You may have to keep the patient in the hospital for 3 days. Now, dilutional coagulopathy. Sometimes this patient come in with a large amount of blood loss, right? You give a lot of blood to keep up, and you end up giving like 3 units of PRBs in an hour, and you end up giving more than 10 units in 24 hours. Be careful. It can cause something called dilutional coagulopathy, and we have to replace the coagulant factors and platelets in that situation. Now, a lot of times, we talk about when the patient is on Coumadin, or we have to be, when can we restart? You wait, let's say the patient have atrial fibrillation, patient is on Coumadin. Patient came to the hospital and you stopped the anticoagulation because you have to do endoscopy. You did all that. When do you tell the patient he can restart it? It's between 7 and 15 days. After 7 days if they're high risk, otherwise between 7 and 15 days you can restart. Now, when do you restart the aspirin and Plavix, okay? So if the aspirin was secondary prophylaxis of cardiovascular, it'd be restarted within 1 week, and ideally within 72 hours in conjunction with you always have to give up the daily proton pump inhibitor also. Again, thank you so much for watching. Please subscribe to our channel. We'll be back with another great topic next time. Please help us subscribe to the channel. Thank you.